Thank you for joining us for this discussion about our cohort study looking at findings in babies with congenital cytomegalovirus, or CCMV, and their risk of developing epilepsy. My name is George Lawson. I'm a paediatric registrar in infectious disease, and I'm joined today by Professor Hermione Lyall, who is an expert in congenital infections and professor in infectious disease.
Hi guys, very nice to be able to tell you a bit about our paper.
So moving on to our study and what we did, we had a cohort of 90 children with congenital CMV who were referred to our central London. As well as clinical assessment and blood tests, they had baseline MRI brain imaging, and these were assessed by two expert neuroradiologists. And they looked for different findings, including things like calcifications, cysts, white matter changes, and particularly polymicrogyria. So going through in terms of our results, 7 infants, so just under 10% of our group, developed epilepsy. And of those, the vast majority had evidence of polymicrogyria. So we found that of the children with polymicrogyria, 33% developed epilepsy, whereas of those without polymicrogyria, only 1 developed epilepsy. And we think that that child had an alternative reason for their seizures. So, Professor Lyall, would you just like to discuss with us a little bit more about polymicrogyria and its anything else?
So I think in terms of congenital CMV, we know that early infection in the first trimester can lead to structural brain abnormality because the effect of the virus on the normal migration of neurons is damaging, and it can lead to cell death and abnormal migration. And we often see in children with polymicrogyria, these are the children who are most severely affected by congenital CMV. And this often also goes along with microcephaly, white matter changes, cysts, and other abnormalities. So we're always talking about the most severe end of the spectrum. Interestingly, in the old classification of symptomatic versus asymptomatic congenital CMV, symptomatic babies at birth were found to have often microcephaly, rash due to thrombocytopenia, growth retardation, and also very often deafness. And on that list of neonatal abnormalities, they also had seizures. But in fact, in our cohort, none of the babies had neonatal seizures. And these children who developed epilepsy with congenital CMV, it was usually into the second half of the first year of life.
And so going on and thinking about those children who did develop seizures, of the 7 who had epilepsy, all of them were started on anti-seizure medications, but it was very difficult to manage, and many of those required multiple anti-seizure medications for some relief from seizures, but none of them achieved full 2-year remission. So, Professor Lyall, what do you think is the benefit in having these findings from MRI and being able to know those children who had a higher risk of developing epilepsy?
So I think having that baseline MRI in the newborn period gives us really useful prognostic information for families, because we can say that the babies who have polymicrogyria, 1/3 of them went on to develop epilepsy, 2/3 did not. We tried to see whether the distribution of the polymicrogyria or the extent of the polymicrogyria, any of that could be predictive, but in this cohort it wasn't. But I think this information is very helpful to families because we can pre-warn them that seizures might be an issue for their infant, and we can also make sure that we teach them how to deal with a seizure should that come along. So I think knowledge is power, and we want parents to be as empowered as possible in the management of their children. And this is very useful information for them and also for other teams involved with looking after the child.
That's great. And so I think that this information can be helpful both for clinicians and, more importantly, for parents looking after these children and understanding about potential developments later on. Within the research sphere, what do you see as being the next steps within research for both in epilepsy and CMV and in congenital CMV worldwide?
Well, I think one thing that is really important is that we know that the most severely affected babies are those who are infected with CMV in the first trimester. And we also know now that if we can find seroconversion in a pregnant woman in the first trimester, then we can actually prevent transmission to the fetus by treatment with high-dose valacyclovir. So working a step backward, it's really about thinking, actually, in future, can we prevent these babies from being infected so that they don't have these very severe long-term consequences? So that, I think, is very important. The other thing is that the old-fashioned quantification that we had of children into symptomatic or asymptomatic predates baseline MRI scanning and indeed newborn hearing screening. And actually, we now need to think about how we score babies born with congenital CMV in a more careful way, which includes a baseline MRI, because that has a huge amount of information to add, not just in relation to whether or not there's polymicrogyria, but we also now know that if there is involvement with cysts and white matter abnormalities, for example, in the temporal lobes, that also increases the risk of hearing loss. And we have the Alarcon scoring system, which looks at all the different factors that you can find and is predictive of longer-term outcomes for children. So I think a baseline MRI is extremely helpful in all babies born with congenital CMV. And I should add that we do see polymicrogyria even in babies who are not microcephalic and who examine normally at birth. And that is one of the things that has convinced me that this is a really important baseline examination.
And so that's great. And I think lots of useful things there and better information for clinicians and better scoring systems that can help both the way that we communicate research findings, how we have a standard for comparing different patients, and how that will help us to better understand which children are maybe going to benefit from treatment, rather than, as you said, the more binary asymptomatic or symptomatic classification. Was there anything else that you'd like to add in terms of future studies?
I mean, I think that we are part of CCMVNet, which is a European registry of children born with congenital CMV. This registry now has more than 1,500 babies in it and follows these children up long term, at least until they go to school, so that we can get really important outcomes, not just in relation to epilepsy, but also in their motor development, in their hearing, whether there's any late onset hearing loss, and in their function in terms of communication, autism, and learning. Because again, the spectrum of what CMV can do is wide. And within the registry, using those longer term outcomes, using baseline imaging, we're aiming to produce a scoring system for newborns which will be more helpful and predictive in the longer term.
That's fantastic. Thank you very much for joining me today and sharing your insights on this topic and in showing me through this project as well. I hope that this study encourages further work into CCMV and improves their management and treatment of are able to offer these children and their